Good morning. We have excellent attendance for our LEICC today. We're going to use the microphones, but you know it takes time to pass the microphone around the table. So what I would encourage is the folks in the back of the room to move up. We have lots of empty seats in the front. I'm going to start with some introductions and then turn the meeting over to the chair of our LEICC. I want to first start by recognizing those individuals who have served on the LEICC and whose terms ended as of June 30th. Dr. Mary DeBay. Some of these folks are in the audience. Thank you, Mary. Tony Rodriguez is here. I saw her. Thank you, Tony. Dr. Lisa Schulman. Kathy Warkala. Also, I saw Kathy. Thank you, Kathy. And Chris Trieber. I don't know if Chris is here. Chris, hi Chris. Chris was our LEICC chairperson until June 30th. Many thanks to those individuals who have served on our LEICC. It is work, it is effort, it's important. We are grateful. We send certificates of appreciation, but that's only a small token of our appreciation for the work that is dedicated to our joint effort. So thank you all. So I'm pleased now to introduce formally our new LEICC chair, Tracy LeBright. Tracy is the Director of Public Health Solutions Early Intervention Service Coordination Program, which provides initial and ongoing service coordination to approximately 6,500 families a year across the 5 boroughs of New York City. She has been working in early intervention for over 20 years. Tracy was the Service Coordination Contact Manager and Lead Trainer for the New York City Collaborative on Early Intervention. Tracy has participated on numerous LEICC subcommittees over the years and was appointed to the LEICC in July of 2014. Tracy is a licensed social worker. She earned a Bachelor of Science from Cornell University and an MSW from NYU. Most recently, she completed an advanced certificate in integrated primary and behavioral health from NYU. So welcome to our new chair, and I turn the meeting over to you.
Thank you and good morning. Before we get started with introductions, I just want to go over the procedures for the LEICC meetings. First, attendees must pre-register, or should pre-register, I should say, on the New York City Bureau of Early Intervention website. Meetings are open to the public, but the audience does not address the LEICC members during the meeting. Audience members may sign up with Felicia to speak during the public comment section. As of May 15, 2014, New York City's local law number 103 of 2013 and the New York State open meeting law requires open meetings to be both webcast and archived. So this meeting is being recorded today. Transcription is also available for this meeting, and written meeting minutes are still available. We have 3 new members that I'd like to introduce to the LEICC. We have Agatha Guadagno. Agatha is presently the New York City Bureau of Early Intervention Regional Director for the Borough of Queens. In 2001, Agatha started working at New York City Bureau of Early Intervention as an EIOD. She was promoted to Assistant Director in 2002, and in 2007, she became the Regional Director. During this time, she represented her borough as a member of the New York State Department of Health's Bureau of Early Intervention Program Task Force to discuss policies and procedures regarding the 45-day compliance. She was a member of the LEICC Subcommittee for Programs and Services, and in 2008 was honored by the New York City Department of Health and Mental Hygiene with the Distinguished Service Award. Prior to this, she taught in various center-based programs for children with special needs, ages 2 to 5. Ms. Guadagno has a Master of Science degree with a focus on parent-infant development and early intervention from Bank Street College. She's also licensed to teach special and regular education in New York State. So welcome, Agatha. I'd also like to introduce Karen Samet. Karen is the director of the Brooklyn Early Childhood Direction Center, ECDC. Since August of 1995, Ms. Samet has a BA in Health Sciences, Speech Pathology and Audiology, an MS in Special Education, and the New York State certifications for public school teacher, special education, and school administrator and supervisor. The Brooklyn ECDC is locally sponsored by United Cerebral Palsy of New York City and is part of a statewide network of 14 centers funded by a grant from the New York State Education Department. The ECDC provides information and referral assistance for parents of children birth to age 5 with suspected or diagnosed disabilities, linking them to services and supports within the community and providing training on relative topics as they navigate the service delivery systems that support young children with special needs. The ECDC also provides technical assistance training for professionals and early child care providers on various topics relevant to the needs of young children with disabilities. Prior to ECDC, Karen worked at UCP of New York City as a special education teacher with preschool and school-age children, and she served as an assistant director of the Brooklyn Preschool and program director of the school-age program. Welcome, Karen. And I'd also like to welcome Jacqueline Shannon. Dr. Shannon is a founding chair of the Department of Early Childhood and Art Education and associate professor in early childhood at Brooklyn College of CUNY. She received her doctorate in developmental psychology at New York University and her master's in early intervention at Northern Illinois University. Dr. Shannon has over 25 years of experience working with culturally diverse children from birth to 5 years with and without special needs and their parents using family-centered practices in home-based, center-based, and hospital settings, which included directing a home-based child development program and co-developing an EI program in East Harlem. Prior to joining Brooklyn College, Dr. Shannon was also a research scientist in the Department of Applied Psychology at NYU and deeply involved in the planning and implementation of the local and national Early Head Start research and evaluation project and EHS father studies, as well as a postdoctoral research fellow for NICHD. Dr. Shannon's scholarship focuses on improving the quality of early education and mental health services to young children and families with the goal of reducing disparities for ethnic and racial minority groups. Recently, Dr. Shannon developed New York's first advanced certificate in early intervention and parenting through the support of the New York City Department of Health and Mental Hygiene Bureau of Early Intervention. So, welcome, Dr. Shannon. So I'd also like the LEICC to just go around and briefly introduce themselves. So why don't we start with
Oh, fine. Linda Silver, Chair of the New York City Coalition and work at Village Child Development Center.
Nicole Brown, I'm an assistant professor of pediatrics at Montefiore Medical Center, Children's Hospital at Montefiore.
Kathleen Hoskins, Assistant Commissioner, Office of Education Support and Policy Planning, New York City Administration for Children's Services.
Hi, I'm Kelvin Chan from the Bureau of Child Care and the Director of Early Childhood Development.
Cynthia Winograd, Administrative Director of Jumpstart Early Intervention Program.
Cindy Chow, parent.
Agatha Godagno, you already know about me.
Rosalda Maysor, Director at Little Wonders.
Liz Isaacson, Docs for Talks.
Karen Salmon, Director of the Brooklyn Early Childhood Direction Center.
Lois Kessler, Special Education Office of the New York City Department of Education.
Jacqueline Shannon, Brooklyn College.
Marie Castellino, Assistant Commissioner, Bureau of Early Intervention.
Okay, thank you, everybody. So everybody should have received the minutes from the last meeting, last week. Hopefully everybody had an opportunity to review them. Because I'd like to make a motion to approve the minutes if nobody has any comments or changes. Can I have a motion to approve? Can I have somebody to second it?
Second.
Okay, and can we vote on approving the minutes? Everybody in favor of approving them? Okay, so we have approved minutes.
The next order of business is a review of the updated operating principles for the LEICC. These were sent out to the LEICC members on Friday with the other documents. What I wanted to do at this point in time is just walk through the significant or meaningful changes to the operating principles. The last version had been approved by the LEICC December 6, 2010, and we need to be able to update them to the current year. Section 1, there were some formatting changes based on the need to modify Section 1, which was modified to comply with Public Health Law 2554 regarding the appointment of LEICC members by the early intervention official, by the EIO. That is required in Public Health Law, so Section 1 was modified accordingly. Section 2 was, this is in the version you have, Section 2 was modified to eliminate the requirement for a co-chair and clarifying that the appointment of the chairperson is also made by the EIO in consultation with the Deputy Commissioner of the Division of Family and Child Health. And the EIO also notifies the Commissioner of Health regarding the LEICC chairperson appointment to the Health and Mental Hygiene Advisory Council, which is an advisory body to the Commissioner of Health. So our LEICC chair sits on that advisory council. Section 4 further clarifies appointments made by the EIO. In addition, there was a clause in the previous version, in the December 2010 version, describing the transition to term limits, which has been removed at this point in time since that action had already been implemented and is no longer applicable since all of the LEICC members now have term limits. Section 11 was modified to require that the operating principles be reviewed every 3 years rather than every 2. So those were the meaningful substantive changes made in the operating principles.
Okay. Anybody have questions, comments? Okay, so if we can have a motion to approve the revisions. Okay, and a second? Okay, and if we can vote on approving the revisions? Everybody in favor? Okay, so we've got approved revisions to the operating principles. Let me turn it over. Oh, okay. Do you want to do that now or then?
So there's one section in here that Tracy and I have had a conversation about and that we need to be mindful of as the LEICC. Public health law does require that the LEICC report annually to the EIO on the adequacy of the early intervention system to ensure the availability of family-centered coordinated services. So that section remained in the operating principles. It has been in effect. We need to consider compliance with that section of the law. And Tracy and I have talked about the best way to go about this. What we thought we would do is there is going to be a discussion further on in the meeting regarding system capacity and some of our concerns. And we could table this discussion till after that presentation, if that's something that the LEICC would consider.
I think it makes sense.
Okay. Thank you.
Okay. I'm going to turn it over again to Dr. Castellino to talk about an award that Jeanette Gong had received.
So we did want to inform the LEICC about an award that one of our staff received in May. Dr. Jeanette Gong was given the Emily Finichel Award from the New York 0 to 3 Network. This is an annual award presented to an individual whose contributions to infants and toddlers through practice, research, leadership, or advocacy are deemed exemplary by a panel of judges. The award honors the memory of Emily Finichel, who served as Associate Director of 0 to 3, the National Center for Infants, Toddlers, and Families, until her tragic death in 2006. The award was presented to Dr. Jeanette Gong on May 6, 2016, and we were told that she is the first municipal government professional to receive this award. And our thanks from the Bureau is a special thanks for recognizing Jeanette for her extraordinary work and recognizing her role within the Bureau. So many, many thanks to New York 0 to 3. We were present at the event, and many, many thanks for this award for Jeanette and also for recognizing her.
Okay, congratulations, Jeanette. Dr. Castellino is now going to give her report.
So as at previous LEICCs, what we've done is significantly decreased the amount of time that I spend on the SEICC report. We've done that for a number of reasons. Our agendas are very, very full, and we feel it's more effective if I present the most pertinent issues through the use of our PowerPoint slides. But also what we've done is forwarded all of the SEICC documents to the LEICC for them to look in more detail at any of the documents they wish to review. So the March 3rd SEICC agenda items included state law regarding quorum and interesting discussion, the Joint Task Force on Social Emotional Development, Medicaid Children's Health Home, and department activities around the program regulations, final executive budget, and fiscal payment updates. They also did announce the appointment of Lauren Tobias as Director of Family Health. Lauren Tobias replaced Brad Hutton, who was promoted within the Department of Health. Lauren Tobias is responsible for oversight of the EI program at the state level. The next discussion pertained to council duties, quorum and majority voting. This is something that had come from a discussion at a previous meeting. The department began with a review of the council's responsibilities, which are to advise, assist, and assist the lead agency in performance of its duties. The current membership is 27 members. The statute establishing the SEICC is silent on what constitutes a quorum. So the question was raised, what constitutes a quorum, how many votes are needed on the SEICC to pass an action. The exception is that the council, upon a majority vote of its members, may require that an alternative approach to the proposed rules and regulations be published with a notice of the proposed rules and regulation. What is pertinent here is, since the statute for the establishment of the SEICC is silent on a quorum, the default is to defer to other state legislation. And in this case, the applicable law is the general construction law, which was passed in the state in the 1920s or earlier, approximately that time, or to defer to what is in the bylaws. So the current membership of the SEICC is 27 members. A majority of members must be present to hold a meeting, which means 14 individuals must be present. And a majority must vote in favor of an action in order for the action to pass, which means that there must be 14 yeses. Abstentions do not count. So that did create considerable discussion at the SEICC. There will be a bylaws change. The bylaws of the SEICC must come into compliance with the established law, and there will be further discussion at the next meeting. In order to change this particular legislation, there would need to be other legislative changes. There was considerable discussion since a number of the members of the SEICC represent statewide agencies, and on occasion they need to abstain from a vote. And membership attendance at the SEICC is not always adequate to achieve the 14 yeses. So considerable discussion, more to come. The update on the Social Emotional Task Force was presented by Mary McHugh, New York State Office of Mental Health, Task Force Chair. The editor is Bob Frawley. I'm reporting from March 3rd. There have been some additional action since then, which I will tell you about. Ongoing work with significant revisions underway. The current status of the task force document at that point in time, we were told that the document was being revised to eliminate the separate sections. There had been section 1, which is a very generic section on social emotional development for all stakeholders. Section 2 was going to be dedicated to early intervention, but we were told in March that there would not be separate sections, but there would be EI-specific information. We were also informed that the document would be sent to the task force members during the summer in preparation for distribution to the SEICC at the September meeting. side note, we did receive the document about a week or so ago. We are going to be looking at it. Those of us in the Bureau that have been working on the document will be reviewing it. There's a meeting August 8th, if I remember correctly. I believe it's August 8th, where we will provide feedback on our review. Health home model, the next agenda item, health home model to serve children. A presentation by Colette Poland, Office of Health Insurance Programs, and Brenda Knudsen-Chaffee, SDOH. They continue to work together on health homes, primarily in March on getting the networks in place. State DOH had been meeting bi-weekly with state health home staff to identify the methods to integrate health homes with early intervention, ongoing service coordination activities. The plan in March was to begin to enroll children in October 2016 with a projected enrollment for EI children, March 2017. Ongoing webinars presented by SDOH. You're going to hear later in our agenda an update on health homes. Billing and claiming in the packages of information and the PowerPoint presentations that we forwarded to the LEICC, you will see several presentations from State Department of Health regarding billing and claiming. Most pertinent to New York City is the decrease in denials from commercial insurance, but also pertinent and concerning the decrease in the dollar amount of claims submitted to commercial insurance via the statewide fiscal agent. And there is additional detail on the State Department of Health, but there is concern about the number of, or the dollar amount of claims submitted to commercial insurance. So with that, that's the SEICC report. Are there any questions?
Okay, so Nora is going to do the data report. And so you should have received the data report yesterday.
Okay, so the first thing to note about the data report is that content-wise, it is the same as last time. We agreed that we wanted to try for at least a couple of stable reports since everyone for the last few has been a bit different, and we wanted to go with something that would give you a chance to get familiar with the data, what it's trying to tell you, and give you a chance to sort of see it over time. Of course, what you're seeing here, unsurprisingly, we all know this, is the incredible consistency of EI activity over the last few years. And we are, really seeing that both when we look at the total, when we cut things out by borough, when we break things out by race. In the last few years, there has not been a lot of change. And a lot of people would argue that part of it is it's just too short a time span. And there's probably some truth to that. As you know, we had a real break in our data abilities with the move from kids to NICE. And as we move forward, we'll have more data and a more longitude for you guys to really see, is there a trend or not? But certainly from 13, we are seeing really no changes, very, very minimal changes in number, percent, and rate of referrals and in receipt of general services. What you might think is an exception is around the rates, where it looks like things are going up. I'm very, very hesitant to interpret that. I'm sorry, Nanette, I never go on order. Because of the fact that we're calculating a rate on 5 months of data based on, breaking out what is really meant by the census state to be a year's worth of data. And I'm very reluctant to say for sure, then if you go to the next slide, that what looks like it's going up I don't want to commit to that at this point because it's just really not close enough to a full year to be able to speak to. We'd like to think that's a trend, but also since we've not historically looked at rates, I can't even say to you, oh yeah, in July we always see this. So we'll have to take a look at that closer to the end of the year. Does anybody have any questions about referrals or general services, which sort of are our usual bread and butter? Okay, so we can go through a few of those. And again, as you know, looking at race is something pretty new for us, and we're not, seeing much change there. We are focused on looking at that, but even with recent outreach efforts, I think they're very targeted. We're starting small to try to figure out what works. And so I think when we look at global numbers, we're probably not going to see big changes quickly. And as we're doing more of these outreach efforts, I think we may want to share with you data that's more specific to where we're doing the outreach or with which populations, because it may not be enough to move a population of 30,000 children. Okay. So going through general services, and then any type of service. Yes?
Question. What are the rates, the proportion based on population within those groups?
So,
Do we have
okay.
any sense of that?
So we'd have rate by city. And if you look at
So,
referrals, for instance,
right, so we know the referral percentage within the boroughs, but we know how that compares to the number of infants and toddlers that are about that age in those boroughs.
so if you look at the rate of referral charts, can you find one of the line charts, Nanette? Well, that's a remarkably flat one, but these are rate by race, or the previous one is rate by borough. Is that what you were thinking? 'Cause
No,
that's
but
how it's
within, so
sold.
within the borough, so if you have a larger number of infants and.
Right, and that's what a rate.
And then it's within that percentage. So
Okay,
if you've got 100 children,
Mhm.
and then 5% of them are being referred, versus 100 children and 20% are being referred.
Okay,
in
so
another
what
location.
would you want to see differently in this rate line chart that tells you out of 1,000 in that
Is
borough?
it, I don't know if it's possible, but is it possible to find out within these different boroughs, sort of what's the number of infants and toddlers that are?
Yeah, no, we know the 0 to 3,
Yeah.
and that's the denominator we're using for the rate of referral by borough.
Okay.
That slide, the second
Okay.
one?
So it's not just the rate within the borough, but sort of within the number of infants and toddlers that are.
Yeah, because otherwise it wouldn't
Okay.
really tell you much if the denominator and the numerator are not the same.
So it's, okay.
Yeah.
Okay,
Yeah, no, we can talk about it some more
Yeah.
if there's a different way you want to break
okay, yeah,
it
no,
down.
that'd be good.
Okay. Anybody else? All right, so when we get past all that receipt of general stages, if you will, we get down to what we added last time that was new, which is the progress of new referrals, Senna, if you go toward the end. Yeah, there you go. So this is the progress of referrals. This is the first time you saw this, was last time, and it tells you two different things, right? It tells you both overall and within the race ethnicity, what is basically the attrition rate from stage to stage across the stages which are referred, evaluated, found eligible, actually get to services. So we clearly saw here what we sort of see elsewhere, but I think it's always clearer here, which is that whites tend to be overrepresented, blacks tend to be underrepresented, and Hispanics actually tend to be very close to their actual share of the total population. And this is why we've been focused on black children in particular neighborhoods where they're really being under-referred or under-retained. And we went through and we broke out each of those by borough, and again, Dr. Shannon, I mean, each of the charts by borough are specific to that borough. This is the one, we did change the percentages a little because last time I think the percentages we offered were a little less illuminating. In these, you can see for each of the color bars that represent a particular race, you can see sort of the transition across the bars.
I like this layout a lot. I
Oh,
found this
good.
layout
This
better
is
than last
readable,
time.
this is understandable? All right, good. Okay, glad to hear that.
So Nora, let me just step in. Remember that we have been talking for a while now about equity, health equity, and it is why we are so focused on the data as it's being presented. And as Nora said, we have significantly increased our outreach efforts into particular communities in New York City where the data show us that children are not being referred in at a rate equal to counterparts in other communities. So that's why we are so focused on referral rates, retention rates, and you'll hear this as an ongoing theme through all of our meetings. So thank you.
Any chance we can get even more granular with the ethnicity data? Like, can you look at language proficiency and
So all of this data comes from NICE. So most people have some sense of the quality of data in NICE. It's not that language isn't entered in NICE, and it's not even that I doubt the language data. It's more that I don't know how much isn't entered in NICE. I'm not wildly optimistic that at the point of referral, people always know, and that if not, somebody goes back later to enter it. My concern is always, if I really feel uncertain about the quality of the data, I don't want to present something that could really be misleading. We don't really have another source of information that we could pull in any kind of automated, comprehensive way that would answer that I can think of offhand. Lydia's going to talk a little bit about information we get, but it's more, I don't want to say anecdotal, but it's more ad hoc, and I can't say that it's representative of the whole population. Okay, so that's the programmatic, and then the final one is about insurance. And, you know, we keep this in here in part because of what was being reported from the SEICC. I've said this before, I'm gonna say it again. There's no way that 19% of our kids don't have insurance. I mean, historically, that would mean that in 2014, 2013, with the advent of NICE, and certainly with the advent to a different payment system, suddenly our population went from 8% historically to 19%. That on top of the fact now that we're seeing this other end of it, which is that, yeah, denial rates are down, but that seems to be because there's less going in, we are very concerned. And we have done some work looking at actually going through the paperwork attached to NICE, looking for those parent forms to see if there's any indication of why, and there isn't. They are simply, you know, they've signed, I decline to share my information. It's a concern. It's obviously, it increases it constricts the capacity of the system, the more the money that's coming out of the city and state. We don't know what's going on there. We also don't know what that means about what's being told to parents about the program. When we're doing some of this outreach, I know it hasn't happened too often, but some of the feedback that Dr. Canary has gotten has been, oh, it's free. If there's misunderstandings in the community about, you know, how early intervention works, what the burden on families is going to be, it can be hard to explain. Yes, we are going to bill your insurance. That has no impact on your use of your own insurance. That's a concern too. It's just, you know, what is that conversation looking like? But we keep bringing this back because it is a concern. And the Medicaid-only population has not changed. It's been about 60% forever.
Nora, in terms of just insurance, I mean, it's extremely complicated for service coordinators to explain. I think the other thing that people are not aware of is that more and more companies are actually self-funded in terms of the private commercial insurance. So that probably has a very big impact because then the parents don't have the protections afforded by the New York State law, so I can understand why they would not want to give their insurance. I mean, I don't know what the percentage is, but I think it's a pretty high percent. I think a lot of large companies are going the self-funded route.
That's interesting. I don't know if somebody like the State Office of Health Insurance might know something about that. I mean, I know historically the big problem has been that neither the parent nor the service coordinator knew if it was a self-funded, plan. They just, they did not know. In the same way that many people seem not to recognize when it's Medicaid managed care versus private insurance. But if that's true, you're right. I could certainly see more parents saying, I'm vulnerable.
Large companies, unions, and you can't necessarily tell from the insurance card.
Right.
Sometimes it'll say administered by, which means it's self-funded, but, I mean, our company, we're self-funded, so if we're a not-for-profit that's self-funded, I'm sure a lot of companies are now.
And I was just gonna go back a little bit to Marie's report, but it kind of goes into your report also. In terms of the city's concerns about PCG and their ability to collect the private insurance money, we spoke about that at the last coalition meeting, and the city has a big stake in it. Is the city involved with a workforce, or Pam had mentioned about a workforce or PCG workforce in terms of their competency in this regard?
We have representation on work groups. I don't know which one. Yeah, I'm not sure which one you're referring to, but we have representation both by our colleagues in finance, and the Bureau is involved in whatever work groups are pertinent to this effort, without question. But our finance colleagues do have concerns about this issue.
Right, I think that's what she was,
Right.
I have in my notes about the PCG workforce and not recovering insurance, and that has a gigantic impact for the city, obviously. So the city itself is on the workforce to try to get PCG to be more competent in that area. Obviously, it affects the escrow money, and the providers want to see better recovery from insurance money, because obviously it impacts them in the long range.
Yes, of course, the statewide fiscal agent, everyone is looking carefully at what they're doing. It was, a transition that we're all exquisitely aware of. But the issue is also the submission of claims to insurance. And what's happening with the submission of claims to commercial insurance in order for PCG and the insurers to, for the insurers to adjudicate the claim, for the money to come back. The claims need to be submitted by the provider community to the fiscal agent, and it has to work its way through that process. So it starts off with question 1, and then you have, question 2, 3, 4, etc. So that was what came up at the meeting, and again, I sent to the LEICC the information that was shared by the state and by the fiscal agent.
So that goes on to, so are you saying that the problem is that the providers are not submitting, because that whole pre-approval process started, I think the last time we had an LEICC meeting, and people were talking to me about it. So that's the concern, that they're not submitting the plans? So
Again, I can't speak for PCG, I can't speak for the State Department of Health, but if you look back at the data that was presented at the last SEICC, you will see that it appears that whether it's fewer claims, less money attached to it, I can't say, but it appears that the claims for services are moving more quickly to the next payer beyond the commercials. So is it Is it that claims aren't being submitted to the commercial insurers, or they're just moving much more quickly through that process for whatever reason? I can't speak to that, Linda, because I'm not either the finance person here, nor are the SEICC members, you know, we can't speak for PCG in this state. I'm speaking as an
Well, here's what's
SEICC.
interesting, and somebody just mentioned this to me, that I can't remember which company, it might be Aetna, but I might be misstating it, right? So Aetna had already said that they're not gonna approve any claims. So because the person who's doing this is pretty confident, when a claim went through to that particular insurance company, they already knew in advance that the company was going to not approve it, and kind of like very quickly resubmitted it. And they got an actual call from PCG Help Desk saying, what are you doing? It was too much of a fast turnaround. But the thing is, the insurance companies have already put certain providers on notice. So what ends up happening, that there's a quicker turnaround in terms of resubmitting it with the denial status, which almost doesn't even seem real, but that's how the insurance companies are operating. So possibly that could be part of it. I don't know.
Okay, any other questions in terms of the data report? Okay. Yeah, Nora's gonna talk about the parent survey.
So there's a lot of text on this slide, but I'll actually be pretty brief. You probably all saw, or most of you saw, an email. We just wanted to let you know, in case you heard from families, that we are doing a parent survey. It will be a telephone survey, but because of public health law is really restrictive around EI confidentiality, EI itself actually has to first mail a consent to the parent to sign, mail back to us, so we can give it to the survey firm so they can call. So we don't know what our response rate is going to look like. But it's about a 20-minute instrument with a few scales. They're all validated, pulled from, validated mostly Denver and I forget the other, but existing instruments. And they are primarily oriented to the parents' sense that the program helped them, helped their child, that they understand better what's going on and how they can help their child. So we did develop it and test it out with an academic and a clinical partner about 2 years ago. Excuse me. And they tested it out, but it was a fairly small sample. It was less than 200 families. The results were very positive. One of the things that was most interesting to us was we did create one scale of our own, and it was around embedded coaching, as we called it. And of course, no parent recognized the term embedded coaching, but they all said that their therapist did it. So that was great. So we were hoping originally for an 1,800 sample, but that was before we knew we needed this additional consent step. So we will see what happens with that. And a few people did call and ask for the survey. The reason I am not giving it out right now is simply because sooner or later, if I give it out, it will make its way to a parent. I want them to hear it for the first time on the phone with the surveyor, not read it ahead of time. So that's the only reason. Normally we try to be transparent, and we will be happy to share it when it's over. And we will share the results in advocate when it's over. But for right now, we'd like to keep it at this level. Gotten very few questions from parents, so hopefully it's pretty clear to them. And we do not ask them to identify their providers, so we won't know that.
Do you have any different languages?
Only Spanish.
No other questions? Okay, so Nora is going to move on to provider oversight.
Yeah. Well, you see how this year is shaping up. It's really hard to say that things are going well, because they're not. Evaluation is looking very disturbing. I also want to point out that OSC, which was originally our biggest problem area, seems to be creeping up as a problem again as well. We've discussed in the last year what is going on with evaluation. That question seems to be turned back to me, and then I have to turn it back to you. It's the same tool. We're measuring the same things. How did we go from 3 years with no failures to this? That yellow means that more than half of them audited this year did marginal, meaning they're close to failure. Many of the failures were actually, we don't show it here, but they were at such a level that we suspended. You have to fail really, really badly for us to do that. I have no suggestions about what to offer here, except that we're extraordinarily concerned, but we're not hearing really productive suggestions from providers either about what they see as the problem and what they think they might do about it. There's just general lamenting of the state of affairs.
So we talked about this a bit at our last LEICC about the evaluations that are being submitted. And what Nora has here on this slide, what we're presenting to you here, are the findings from provider oversight which focus on regulatory compliance. Our concern goes beyond regulatory compliance. Our concern goes toward the quality of the evaluations that are being submitted to us, and our need to be working intensively within the provider community on evaluations. Evaluations are what bring children into the system. They are what we all work on to identify what the child and family will need going forward. So it is, every step in this process is critically important, but I'm sure everyone around this table understands the importance of evaluations. So that being said, our evaluation standards unit has been looking at the evaluations and the kinds of things that we are seeing within the evaluations that raise concern. We're still moving towards how to resolve this and how to fix it, but Dr. Canary, if you can speak to some of the issues regarding the evaluations that have come into the Bureau to establish a child's eligibility.
Sure. So I work with Dr. Schreiber, who's oversees the Evaluation Standards Unit. She's the director of the unit. And we've recently been trying to, anyway, we look at probably about 7 to 10% of the evaluations that are done in the city each year, I think, make their way to the ESU. And some of the concerns, one of the big issues that I see and that the ESU sees is a lack of synthesis of the findings of all the members of the MDE team in the MDE summary. The summary is basically just a regurgitation of what each person's report is, and not a synthesis of whether if one person's findings are discrepant with someone else's, how are those integrated, and what's the conclusion, and is the child eligible or not. Often there's lack of clear support in the summary for whether a child's eligible or not, and somebody may be entering information in NICE based on information that's in the MDE summary that isn't really what the evaluator intended in the report. This is clearly a problem. Sometimes the summary isn't even written by a member of the MDE team, so it's really hard for them to put things together if they weren't a member of the team. There are bilingual issues. Sometimes we see that bilingual evaluation isn't completed when it would have been necessary. Parents will sometimes ask, oh no, I don't, my kid, I don't need a bilingual evaluation. Parents cannot request that. If they request that, they don't get evaluated. Often there is failure to document how the evaluation procedures were responsive to the cultural and linguistic background of the family. There may be inappropriate use of interpreters. We recently had reviewed an MDE with an agency that predominantly had, it was Russian or Chinese or some, another language, sorry. But they were evaluating a child whose family was mainly Spanish speaking, and so the Spanish speaking SLP translated for the special instructor when the agency just shouldn't have taken that case and should have passed it under an agency that could do an honest-to-goodness bilingual evaluation. Sometimes there's a lack of appropriate or qualified personnel to evaluate the concerns. that were expressed or the reason for referral. Sometimes the need for supplementals isn't even clearly indicated. We've seen several, like young infants without any remarkable medical history getting PTOT speech and special instruction evaluations. And these kids, we're not talking, ex micro preemies with an intracranial hemorrhage. These are just little kids with, lack of tummy time, and yet they're getting these huge evaluations, and it's not clear how the initial core team decided that they needed whatever supplementals were added. Sometimes the parental concern isn't even addressed by the MDE team, or it may not be investigated in detail. Sometimes we read stuff and it's like, well, we have questions and we're wondering why the MDE team didn't have similar questions and investigate them more fully and put them into their report. Sometimes there's what appears to be a limited knowledge of child development. Now, I don't know if this is because evaluators are used to working with preschoolers or school-age kids, and now they're looking at infants and toddlers, and development maybe well, obviously milestones are different when you're younger. There's inappropriate use of clinical clues. Sometimes the evaluations are not well timed. A kid had surgery 2 days ago, or they hit him during nap time, or whatever. So obviously these are not found in every single report that comes to the ESU, but it's not just one of these that's seen in each. There are usually several issues that are of concern to the ESU team when they're reviewing MDEs. So anyway, those are just some of the issues we see, and we don't have any. We actually are always saying, how can we help these agencies do better? And we don't have any solutions for that, although we wish we did. And I don't know if any of you might have suggestions or questions.
The reports that you review, do you have any way of knowing, a lot of this is done in the home, do we have any way of knowing the training level of experience that the evaluators have? I'm thinking a more seasoned evaluator might do better on some of these individual things you're bringing up.
So that's a very good point and a very good question. The bottom line is when an evaluation is submitted to establish a child's eligibility so that we can move forward with the appropriate services for this child and family, the agency or the evaluator or whoever prepared that evaluation should be responsible for ensuring that the appropriate individuals did the appropriate evaluation at the appropriate time. So while your question is good, our ESU staff and our regional office staff and folks are looking at evaluations that do not meet an acceptable standard. So if an agency is sending someone in without the appropriate qualifications, we need to take issue with the issue. So well, why are they doing the evaluation if they don't have the qualifications to do it? So I'm sorry, but I understand what you're saying, but there is a responsibility to those individuals that are completing the evaluations. They should meet the standards. So I understand your question, but for obvious reasons, we are concerned, and our staff are spending considerable time working with agencies, with individuals, with evaluation, providing technical assistance, but this is an issue for the field, and we need to look very carefully at this and determine what we're going to do to fix it.
I'm not commenting this to disagree with what you're saying. I totally agree with what you're saying. It is the responsibility of our site to ensure the competency of the evaluation. But I'm just wondering, in terms of the comments that Dr. Canary made in terms of issues that you're finding, and the first thing you said is the synthesis of the findings in the evaluation evaluation summary. I'm wondering if the actual evaluations are in question, or there's a lack of understanding of what it means to submit an early intervention evaluation and the standards of an early, in terms of writing that evaluation summary and what's anticipated in the evaluation summary. So is it the evaluations themselves that are not meeting the standard, or not understanding early intervention? Both.
The team doesn't just read the summary and say, oh geez, this
No,
can
I didn't mean to say that.
But no, there are issues throughout.
So the evaluations themselves leave something to be desired, as well as
Yes,
understanding what
yes.
goes into the summary.
Yes.
Thank you.
Is there some sort of like kind of streamlined place for people that are doing the evaluations to have that standard of evaluations? Like if there was a certain webinar or something that outlined everything, or how are people kind of learning what the standard is?
There are lots of, Faith probably knows better than I do, but there are lots of webinar, in fact, we just did a training last week, and there are multiple sources of information. There's several websites put out by the state. Our technical assistance unit works with new agencies as well as agencies that are having difficulty. It's complicated. I was a clinician. I've done EI. It's a lot of work, but it shouldn't be difficult if a provider wants to do a good job to figure out what the requirements are and to meet them. It's work, but the information's available.
We also ran a full intensive training with Dr. Kate Crawley on culturally and linguistically appropriate evaluations, and we did it for special educators. We had one that was only for speech pathologists. We had one for QA turnout. It was a fabulous training. The turnout was not so great. We had a good amount of people there, but we had space for a lot more. We had a lot of people that didn't show up. We've offered training. The state has a lot of really good training. There's the clinical practice guidelines. The information's out there. It really comes down to, I think, around quality assurance.
So, to jump in, hello, is this on? Can you hear? So, am I speaking very loud? Can you hear me in the back? Okay, so we need to move on in the agenda. This is a very important issue. We did want to take the time going from the data report into our issues about the quality of the evaluation. But to end this portion of our discussion on a positive note, we're bringing this to our LEICC because we have work to do. And we're bringing it to the LEICC because as representatives of agencies around the table, this is something that you really all need to be looking at very, very carefully. And I have to tell you, Linda, I have not directly quoted you, but quoted you on a number of occasions after a meeting we had within the last month or so, that you said it's not easy to write a really good evaluation for early intervention, and we recognize that. That's why we're providing all of the support to the provider community to be sure that the people that are doing the evaluation have the background, the information and knowledge, and we provide the technical assistance, and we do the outreach, and we work with the people. It has to be something that the provider community at this point embraces as improvement of quality on the evaluations. I don't want anyone to go away with a feeling of negativity, but if there's an issue that needs to be corrected, we need to bring it here for discussion and continue to do what we're doing around trainings and technical assistance, et cetera, but we do need to move forward in improving the quality of the evaluations in New York City. So this is a collaborative effort.
But I I also say if you want to play in the game, you have to play by the rules. So there's that other part, yes.
Nora, I have a question just about ongoing service coordination. Do you have any specifics that you can share? Because I think this is very alarming, both in terms of evaluations and ongoing, but
That always goes back to the fact that if you had findings, they're in your audit report. If you did badly in OSC, you know exactly which indicators you did badly on. I think going forward, we would actually like, as you know, to start doing more aggregation. We've started being able to do more granular analyses, like with the chronic failure indicators this year. But as far as an individual agency is concerned, if you did badly on something, we told you exactly what you did badly on. And there's really no reason for that individual agency, at least, not to go deal with that issue.
right, I was just wondering because it's increasing, so.
Yeah, I think
You know,
at the end
is
of
there
the year-
something now out there just in terms of sort of,
Same question with evaluation, what has changed, yeah. I just want to throw in a couple more things from the PO perspective and then I'll go away. One is to remind you, a non-MDE team member writing the MDE summary isn't just bad practice, it's a regulatory violation and we'll take your money back. Don't do that. Although it's anecdotal, we have seen a lot of, it's actually the old-time evaluators who can be a real problem because they've been doing things the same way for 20 years, and they'll say that, I've been doing this for 20 years, why are you telling me? So I wouldn't assume that longer years of experience means a better quality evaluation. I also want to segue from that a little bit to new agencies for a moment. Lydia will give you a little more information on them, but we are seeing a lot of bad evaluators and also bad service coordinators and bad therapists who frankly, intentionally or not, are targeting the new agencies. You know, they're people who don't really necessarily know what they're doing yet, they really need to staff up, and they're very susceptible to that. Don't always know what to look for, you know, they were an individual therapist but don't really know how to screen and hire and so forth. We'd like to get the word out there. I know none of you are brand new, but you know, if you speak with people, you know that they need to be very careful about checking references, calling where people worked before, and so forth. We have a lot of concerns about the new agency's performance. Part of it is that usually their management is very inexperienced, usually they're under-resourced, but they are definitely also having folks who are starting to get pushed out at places that are like, I've had enough of having your evaluations kicked back by ESU. Here's a good opportunity to go somewhere where nobody knows that. And we'd really like to see that word get out a little bit more as they join some of your trade groups, or you're just talking with them, you know, to please let them know you need to be a little more vigilant.
Okay. Thank you, Nora. Dr. Canary is going to talk about the clinician's guide and algorithm, as well as MD prescriptions for service.
So, as you probably know, a couple of years ago, there was with the previous medical director and the team that was here at that time, there was a desire to create a simple tool for primary care providers to use with any child under the age of 3 to help in deciding when and how to refer to early intervention as they go about doing developmental surveillance and screening in the course of providing well child care. And we also wanted to help clarify the entire early intervention process from referral to MDE to IFSP to services to transition at age 3. So the clinician algorithm portrays these steps in a simple graphic form, and there's an accompanying clinician's guide that provides additional detail about each point in the algorithm. Next week on Monday, there's a webinar with AAP leadership to sort of introduce the algorithm and guide, which have just been like hot off the press. And I have been, Dr. Castellino and I have been doing some formal presentations, grand rounds, speaking with practices in some of the low referring or low retention neighborhoods, and going forward we'll be using the algorithm and guide as part of our presentation. This information will also be available online, and we'll be mailing it to pediatricians, family practitioners, nurse practitioners, so that the information is available. So this is the front page of the guide. Next slide. And this is what the algorithms look like, which is a little bit small, but algorithm A basically displays the clinician's role during a well child visit. So it includes, looking at information, surveillance and screening, and helping the clinician determine whether they should consider a referral to early intervention. Algorithm B outlines the steps in the EI process. There are different colors are used to denote different tasks of the primary provider's jobs or tasks in the EI process are in blue. EI tasks are purple, and yellow are decision points. So this is just a shot of algorithm A. This is actually a slide from next week's presentation. That's why there's some stuff on there about parents' concern. We'll be presenting a vignette of a child to sort of make the whole use of the algorithms come alive for the people who participate in our webinar. But what I wanted to point out is that each box in the algorithm corresponds to a detailed section in the clinician's guide. So that box A8 correlates with this section of the clinician's guide, which talks about parent agrees to referral, and there are some resources at the bottom that if the clinician wants to, they're thinking about, I want to refer this kid to early intervention, maybe I need to do some other workup. There are some additional resources that if you click on these, it'll actually take you to an article that is pertinent to that part of the process of seeing a kid or referring them to early intervention. So then I just wanted to move on to another topic, which a question was raised by the LEICC Executive Committee about prescribing for therapy in light of recent legislation about electronic prescribing. So e-prescribing went into effect at the end of March, but e-prescribing only refers to controlled and non-controlled substances. It's only drug prescriptions. And there are plenty of exceptions to drug prescriptions and e-prescribing as well. This has nothing to do with therapy, durable medical goods, assistive technology. Those don't fall into this category. And I can tell you that as someone who oversees the assistive tech unit, we have had no difficulty getting prescriptions for DME, hearing aids, orthotics, whatever, from providers. So they shouldn't be giving you any difficulty about prescribing for therapy. I talked to a clinician colleague who pointed out that clinicians can continue to use official New York State prescription pads, which are easy to order online and they get mailed really quickly in my experience. Some clinics have sort of a generic therapy form and the doctor signs at the bottom and checks off which therapy it is and how many times a week or whatever. And some provider agencies have their own therapy forms that they mail to the provider. The provider signs the bottom and checks the box. So there isn't any reason why a physician or a medical provider should be giving any difficulty about prescribing for therapy or assistive therapy.
Any questions?
Any questions?
Okay, so thank you. So we are going to move on to Lydia and the health homes update.
All right, good morning. So the first topic, I'm going to cover a couple of topics that were of interest to the LEICC Executive Committee. The first one was health home implementation. So given that there's several new members on the LEICC, I just want to kind of take a step back and offer a little bit of context as to what health homes are. So, health homes are care coordination services that basically this is an optional state plan benefit that was created by the Affordable Care Act. And the goal, the statewide goal is to make, a care coordination available to some 200,000 children in New York State. In order to be considered potentially eligible for a health home, the child must be enrolled in Medicaid and have either 2 or more chronic conditions or a single qualifying condition of HIV/AIDS or a serious mental illness / serious emotional disturbance or trauma and be at risk for another condition. When we consider this from, what does it mean for EI, when you think about chronic conditions that may potentially make a child, eligible for a health home, conditions like, cerebral palsy, autism, chronic hearing loss, cleft palate, developmental delays, even something like developmental language disorder could make a child potentially eligible for a health home. Now, for those children that are potentially eligible for a health home, the idea that the State Department of Health is putting forward at this point is to allow for the child's ongoing service coordination to be provided through the health home, while the initial service coordination would stay with early intervention providers. So just, giving you that context, I think that this slide makes a little bit more sense. So health home enrollment, statewide has gotten pushed back. We were expecting to see October 2016. We're now looking at December 2016. There is a tentative early intervention rollout now, which would be for March 1st, 2017. This, for the EI portion, it will still require a state plan amendment and formal Medicaid approval, which has not been received. So the state right now is working with the health home office at the State Department of Health to sort of figure out the appropriate intersections between early intervention, service coordination, as well as creating trainings. I think our biggest concern from a city standpoint is what will happen in the gap of time between December 2016 and March 1st, 2017. Allow me to offer an example. So we know that in December 2016, children, associated with ACS and foster care, a lot of their care coordination may be moving into health homes. Okay, so we've been told very clearly by the State Department of Health is if the child is in early intervention and then for some reason, has to go into foster care, those two streams will remain separate. They're going to get EI service coordination and they're going to get, separate care coordination through the other system. However, the piece that has yet to be resolved is if the child's in foster care and they get enrolled in a health home, and then the need for EI presents itself, which is likely, right? What happens then? What system gets to retain the care coordination? So we're actually really concerned about this point because the State Department of Health has not offered guidance to that effect yet. We doubt that the State Department of Health will want to disenroll the child from a health home if they're already in one. But, from an early intervention standpoint, this does offer, this has created considerable, sort of concern for us because we definitely don't want children to, go with that. We just want it to be clear as to what system. So that's really the health home. There's a lot more to say about health homes, but that's it just from the EI standpoint. Does anybody want to say anything about health homes? Okay. Next slide, please. And the next one. So I'd like to sort of give you all an update. The New York City Department of Health and Mental Hygiene, particularly with our colleagues in childcare. We are proposing an amendment to the New York City Health Code, which we're hoping will improve the access to children with IFSPs and IEPs in childcare settings. The technical amendment to the health code clarifies the requirements for access for support service personnel, which appears in Article 47 of the New York City Health Code. So the health code currently requires that any child care permittee that they necessarily arrange fingerprinting and clearances through the SCR for all staff volunteers unless there is direct supervision. The proposal clarifies that centers must allow both EI and CPSC therapists and teachers to deliver services in childcare settings, and it eliminates the redundant requirement to keep, sort of files and profiles on all of these people at the childcare setting. And we believe that clarification will ease access between systems. Next slide, please. So the next steps are, there's a public hearing here tomorrow on various Article 47, modifications, proposed modifications, and this issue is also open to public comment tomorrow. Written comments can also be submitted before 5 p.m. also tomorrow. After the hearing takes place tomorrow, the Board of Health will vote on the issue at their September meeting. And so the link is there, for your reference. If anybody would like more information, I'd be happy to sort of provide it. Any questions on the proposed amendment to Article 47? Okay. Next slide. Okay, so agency updates. Next slide. So this, you are all familiar with this chart. It basically shows the growth of the early intervention provider community since April 1st, 2013. April 1st, 2013, we had 85 providers. As of July 21st, we have 125 providers. And as you can see by the chart, there has been growth in most areas. Initially we just saw growth in services, but I think over the last really year and a half to 2 years, we started seeing a much more significant growth in both SC providers and MDE providers. Now think back to the audit results. That's just my ad lib there, but so we have an additional 65 new and existing providers that are in our New York City technical assistance process that are preparing to either open up shop or expand, the services that they will be delivering. Our provider directory is fully updated and available on our website for all of you to circulate to your staff to assist with service location. Next slide. So, I think a lot of times after I presented the previous page, we were asked, what does that mean for service capacity? And the answer that we've given historically is, well, we're not sure. What we have here is data that the Technical Assistance Unit has been gathering for many years. We have aggregated it, and we think that at this point it's in a good position to show you what the system looks like in terms of service request receipts. So these are inquiries and requests for assistance that come into our Technical Assistance Unit asking for help to find various services, therapies, etc. So as you can see, we have seen a dramatic increase in the number of requests that we are receiving in the Technical Assistance Unit for to help find services for children. It is and it's particularly notable that in just a few months, we're going to outpace 2015, by a significant amount. Next slide. So when we start to kind of, sort of look at these data, we will see that the proportion of contacts from the Bronx and Brooklyn has increased, while the proportion from Manhattan has decreased. So we showed you sort of the first year of requests versus this most current time period that we have. So our request, we used to get 60% of all requests for assistance from Manhattan, and now we get significantly more requests from the Bronx and Brooklyn. And a particular note in the Bronx, most of the requests are coming from 8 zip codes. And we can share those zip codes with you if you like. I don't have them here, but we can send them around. So I think that that's actually pointing very clearly to where that there's an actual capacity issues that exist within our system. So next slide, please. So let's look at service types, So occupational therapy was the most commonly requested service type in terms of assistance, but it has been surpassed by physical therapy in recent years. OT and PT have always accounted for at least 50% of all of our service requests. And what's notable is that the proportion of requests that are for speech has nearly doubled since 2012. And the three together, OT, PT, and speech, accounted for 84% of all requests from January to April 2016. Next slide. When we look at the languages, I don't think anybody's going to be surprised here. I mean, whenever anybody's looking for bilingual, it's mostly for speech. I think that is really carried through in this data. Most common requests for speech is obviously Spanish, but then it's followed by Russian, Mandarin, Cantonese, and Yiddish. So that is the technical assistance data. Once again, it does not give us a system-wide view of capacity, but this is sort of the best we can do in terms of aggregating our service request data. This does not aggregate the data that is received informally by the regional offices. They get lots of requests. I'm sure Agatha can speak to that. Are there any questions about these data?
So, as Dr. Castellino said, we need to talk about how, as a council, we're going to fulfill our obligation to report annually on capacity issues.
I guess that leads to one of the questions that was going through my mind when I saw the data, the really doubling the size of requests, some areas tripling for the technical assistance unit. How has the unit been able to deal with that increased workload? Has it increased staff? I mean, what are the needs of the unit to address this increase? Because I think that's always something, great job, but like, how are you surviving?
Okay, anyway, so we add the line, Dr. Castellino provided us with another line to sort of monitor this, but I think that, we are at the point of needing to really look at what procedures we put in place in terms of reporting this to us. What I'm concerned about is if we modify the process and make it more cumbersome for service coordinators, they will report less, right? And so that's really going to, hinder, and Tracy, I know, has been talking to the director of the unit about, well, maybe we can give you reports in aggregate, et cetera, et cetera. And for a big provider, look, that might work, but for a small provider, when they just have service coordinators out in the field and they're making phone calls and submitting requests, I certainly wouldn't want So that's something that we really need to think about, because we have a start date of service policy, and it's there that we really specify, okay, if you're not finding services, within this date, you should submit this type of information to us. But if the requests continue to increase, we're really gonna have to rethink what our procedures are in terms of that reporting.
So you mentioned getting the extra line, have you added extra staff as well?
Extra line, one more staff.
One more staff.
Yeah.
Okay.
Yeah.
I think that I know my staff has done a better job of reporting, but I don't even think you're capturing a portion. Because it is cumbersome for them to report. And I think the unfortunate reality is, even though everybody would love to find these services, it doesn't really help us actually, in most cases, find the service, because people are calling all the different agencies.
But I think what this data does do is, it may not give us the full scope, but I think in terms of breakdowns, given that we're looking at, 1,500, 1,500 reports, I think it does give us a flavor and a breakout of what's going on. So I think from that perspective, it could be meaningful from a program planning standpoint. But at the same time, no, it doesn't capture everything. And we don't have Nora and I have talked about this countless times with how you do it, how you capture it, what is the best proxy measure here.
And Lydia just mentioned the key word here. We're using this as a proxy measure. We know if our provider community has reached into the Bureau to assist with identifying services for a child, they've tried everything. So the fact that we're hearing more means it's happening more. It's Tracy and I had a conversation about this. Her staff are doing absolutely everything they can, and then they come to us. So the capacity issue is in New York City, as we're hearing about it throughout the state. We'll continue to monitor it. We're bringing it to the attention of our LEICC because it's appropriate to do so for us to think about next steps, but also, as we discussed at the beginning of the meeting, one of the responsibilities of the LEICC is to report on the system's issues. So we'd ask at least our executive committee to think about going forward how best to pull this information together. We as a bureau report up. So once the information is brought to us, we can determine what next steps to bring forward. I also sit at the SCICC, and I bring this to the attention of the appropriate staff at the State Department of Health whenever there's the opportunity to do so.
Sorry to be the cynic, but I'm just curious about this huge increase over the years and how the potential for abuse of the system may come into play as a concern. In particular, I'm cognizant of how important it is to create a reporting structure that is somewhat cumbersome for that purpose of screening opportunists out, but has there been a focus or a crackdown or any imagination into what it might mean to be piping in potential requests for services that may be actually unnecessary?
That's a very good point. And we've talked about this, to what extent is the increased reporting an artifact of the fact that the technical assistance unit is there, it's very responsive, they bend over backwards, et cetera, et cetera. I think that there may be some truth to what you're saying, but I think that we have been hearing about service capacity issues for a while, in EI, particularly in the last couple of years. And as somebody who, I oversee the technical assistance unit, and what I hear and what I always come to provide providers, when the staff is talking to them, is what services are you offering? What do you have? You know, they'll send us a list and the people and say, who's unique here? Who's new that's coming into EI for the first time? And not many, right? It's just the same contractors that they're just adding to the roster, you know, that are already, you know, working for other agencies that are not, it's not like they're saying, well, I'm gonna, instead of taking, you know, 4 cases a week, I'm gonna take 6 cases a week. They're just saying, oh no, I'm just still taking 4 cases a week. It's just that I can take them from these agency, from this, you know, panel, as opposed to another panel. I don't know what you guys are hearing.
I think this is a really important topic. Unfortunately, we need to move on to the group developmental, but what I'd like to suggest is that we convene a task force of interested LEICC members, and certainly if there are providers, you know, who can contribute to the conversation, can figure out how to report on this and, you know, brainstorm if there's anything, you know, we can do to assist to make it better.
Okay, next slide, the final topic, which, you know, group developmental services. So the State Department of Health issued group developmental intervention service standards in November 2013. The guidance clarified group length expectations, which are specifically that the duration of a group developmental intervention must be a minimum of 120 minutes and a maximum of 180 minutes. And when one GDI session is authorized per day, that each group must be a minimum of 120 minutes. The New York City Bureau of Early Intervention is being mandated to comply with this requirement, with this recommendation from the state. We know that, you know, the early intervention group developmental intervention landscape is eclectic. There's all sorts of models out there, but at this point we have informed agencies regarding the necessary changes to group length, and we are working with early intervention staff, the regional offices, and the agencies regarding plan, you know, sort of model modifications, and we are aiming for August 15, 2016, to stop new authorizations to groups that do not meet the New York State Group Developmental Intervention Standards. So if anybody is interested in looking at the Group Developmental Intervention Standards, they are online. I can certainly send you the information. Yeah, so that's really where we're at. We know that it's a very aggressive timeline, but it's necessary for us to come into compliance at this point.
Okay. So I'm happy that's on the agenda, number 1. And, you know, it doesn't affect an enormous amount of agencies. I think you had told me it was 14. Right. So it affects 14 agencies within the city, but 30 locations, right? 30 site locations. So I've spoken to a few of the people, and of course, it's like change your whole life in, you know, change your whole life in 30 seconds. So they're obviously, first they're in shock, and now they're trying to figure out, you know, how to go forward. So, and I've mentioned this already, but I think one of the things, aside from they feel that the state kind of pulled the carpet out underneath them because they've been operating like this for so many years, and that document has been out there since, what, 2013, and here we are, you know, all these years later, and all of a sudden it's like, you know, hurry up and do this real fast. And so they're kind of like stunned by the urgency that, you know, that the transition isn't a little bit more forgiving, and they're figuring out what to do, but they're very concerned about challenges that they might face, it might mean they have to increase staff. We've already gone over the fact that there's shortages. It's, like, you didn't make special educators a primary shortage, but there aren't that many teachers out there, because in the 4410 world, we're experiencing a great deal of shortages in special education teachers. So they could be shortages in teachers, they may have contracts, they may have rent, lease issues. So I think everybody's just kind of stunned and then figuring out. And what, I don't know, like, how many kids does that totally affect? I don't, like, citywide, do we know that?
Yes.
Oh.
So it affects around, if you're not looking at the transitioning population, it affects about 400 children. We have done moves like this in the past in short periods of time. I can tell you that firsthand. I think that we are committed to working with providers. We want them to submit their plans to us. We will work with them. We will find, we're not, we're not going to leave anybody in the lurch. We're not going to leave children without services. We're not, that is definitely not what's going to happen here. But we need to take proactive actions to demonstrate to the State Department of Health that we are coming into compliance with the group developmental intervention standards that were, as you correctly said, rolled out in November 2013, and it is 2016, and we are not in compliance. So.
And I think from the people I spoke with, they totally understand. This is not a city initiative. They understand, like, even on the conference call, they felt that the city was very empathetic to the challenges ahead. But, from somebody just looking at it, it's like the state all of a sudden has this immediate urgency, and it's been on their drawing board for a while. So there's some level of what's the deal, right? But they understand where it's coming from. They're just trying to figure out what to do.
We've already received, proposals from several agencies about their modifications, so that's promising. And we know that some of the agencies that offer a wider array of group types, it's going to be, more challenging for them to figure it out. But we will work with them in the regional offices to ensure that, that we do what's right. And if we have to go back to the state, we can, but they're not very flexible about the state.
Thank
I'm sure you're gonna do this, but it'll be important to loop service coordinators
Yes.
into this. I imagine the paperwork is gonna have to turn around pretty quickly.
Hi, Tracy. So what we're going to do is send an email to the field informing the field that this change is occurring effective August 15th. And as Lydia said, we don't have a lot of leeway. We've definitely tried to advocate, push, beg, borrow, steal, whatever we had to do, but this is it. And so what we're asking all of the providers to do is really work with us. We know it's difficult, it's not easy, it's just necessary at this time, and for more reasons than one. And what we need to do is just try to work together. The regional office is ready and primed. The EIODs will begin having this conversation with the families at the IFSP, saying, this is the time expectation, we will approve this to this August 14th, after August 15th, it's now 120 minutes, one group, if the providers don't have a plan in place. Additionally, I've spoken to DOE, Office of Pupil Transportation. They are ready and primed. They know that this is happening. So we have put in a lot of effort quickly to ensure that this transition is seamless for the parents. For us it might be a little disruptive, but for the families, we really don't want them to feel as though they're losing anything, which in many cases they are not. And we want to make sure that that message is sent to families, and that's clear. Thank you.
So, Loretta, just that August 15th date, just go back on what you said. The authorizations for the change in program presumably takes place as of August 15th for any new children who are entering?
All children should be transitioning by August 15th. That is the expectation. So once we receive your plan, due date July 27th, and we will respond to you by August 1st, at that point, we should have some understanding of what your group is going to be and what we will be approving. That approval will mean that you have met all the qualifications. It's either 120 minutes or up to 180 minutes, and then we will inform the state. August 2nd, those IFSPs, including the regional office and NICE administration, will begin the process. Prior written notice and written notice will go to families. So hopefully that answers your question.
The only question I have is if there is a particular program who's facing particular challenges and they're not able to meet those guidelines, what does that mean in terms of children they might have been anticipating coming into their program, or children who are into their program, if they need some additional time to get their act together, additional space, whatever it may mean?
It means we need to have a conversation, and we will have to loop in the State Department of Health for additional guidance. And so we took those considerations we thought about those considerations when we advocated with the state about the date and the change. And this was the solution that we were able to come up with. If someone is the exception to what is now going to be the rule, we definitely have to have a conversation, but our expectation is that that doesn't occur. We're hoping, but we will have to have a different conversation at that time.
So individual people will know too.
Absolutely. July 27th, folks have to have their plans in place, and we need to be able to, we have a quick turnaround because we need to get back to you by August 1st to tell you if your plan is accepted. And then we need to tell the State Department of Health what the outcome of the plan submissions are. So by that point, they should be able to tell us. The submitters need to be able to tell us, look, I can't do it, or whatever's going on, with a good justification. It can't be, I can't because I can't.
Because I don't like it.
Yeah.
I understand that. But if they do have a reasonable justification, we will take it to the state. You'll take it to the SDOH.
Right, but it's not going to be.
Okay.
Any other questions? Okay, thank you, Lydia. We're going to move on to quality initiatives with Dr. Jeanette Gall.
Okay, good morning, everybody. Lynette, the next slide, please. Thank you. Okay, so what I'm going to do today is just give you an update on our academic partnerships. I'm going to start with Brooklyn College first. They have been working with solidifying fieldwork partnerships with EI providers such as TheraCare, ICLC, University Settlement, and Aspiring Munchkins, with programs that have infants and toddlers with and without special needs, such as their own Early Childhood Center and the New York Early Steps Family Center, which is Early Childhood Head Start, and within medical and hospital settings such as Bellevue and Brookdale. They're also preparing for their online advanced certificate in early intervention and parenting that was approved by the State Department of Education in June 2016. This is pretty exciting because that means it's taking the advanced certificate program into, I guess, modern times and having the availability of getting this advanced certificate online for many of our EI professionals who are interested in taking them. The first courses to be offered will be typical and atypical physical development in infants, toddlers, and young children. And the second course is supporting diverse families and parent-child relationships. It's probably going to start this fall. Okay. The other thing is all early childhood educators can now take Brooklyn College Extension in early childhood bilingual education, whether or not they receive their initial early childhood education training at Brooklyn College. I also want to mention that Borough Manhattan Community College has a 2-year early childhood infant toddler program. So Brooklyn College is laying the groundwork for a 5-year infancy EI study plan with BMCC. Therefore, this would lead their BMCC students to get their bachelor's and then their master's in education at Brooklyn College. This is really great for sustainability. And lastly, I want to mention that they're currently developing an advanced certificate in developmental applied behavioral analysis to prepare early childhood educators to work as board-certified behavior analysts within a developmental and family-centered context. So that's the updates for Brooklyn College so far. They have a few things to do this coming year. The next one I want to talk about is SUNY Downstate Medical Center. They've begun their first year of courses for the specialization in early intervention for occupational therapy program. They started this in June 2016. They have a first cohort of graduate students, about 6 OT graduate students. They're taking the specialization. The courses include Introduction to Early Intervention, Occupational Therapy and Early Intervention, and Topics in Early Intervention, which focuses on family partnership experiences and family observations. Professor Lenko and Professor Thomas are also working closely with Dr. Valencia at the SUNY Downstate NICU to provide a fieldwork experience in that NICU for the OT students. And I want to add that the students, the OT students that are in this specialization actually have to apply to be part of this EI specialization. And not all of them get accepted. So you're getting actually, I think, the cream of the crop, so to speak. Let me talk about Hunter College now. Shelley Horowitz, who we've been working with the last 2 years, has moved on to Stony Brook, and Professor Patricia Gray has been appointed as the Director of Continuing Education and Training. Last year, they ran a couple of pilot courses to see how they would run at Hunter College. And they've decided to focus on continuing education courses that are 4 to 6 weeks long. Each course will cover essential topics for working in early intervention, such as family-centered practices, typical and atypical early childhood development, reflective practice, cultural competency, and the parent-child dyad. They're also planning on applying for CEUs across disciplines to encourage a diverse group of EI professionals to register for these continuing education courses. Queens College. They have completed the curriculum for their 8 courses that will make up the new Integrated Masters of Science in Education and Early Childhood Special Education and Bilingual Education. The curriculum is aligned with evidence-based professional standards from the Council of Exceptional Children, Division of Early Childhood, and the Teaching English to Speakers of Other Languages. They're also in alignment with our 5 tenets for early intervention. They will be working on presenting the new courses for the master's program to the CUNY Board of Trustees and the New York State Education Department. They're also working on Fieldwork Practica Manual because they will be looking for also fieldwork partners in EI agencies. So it's important to note that Brooklyn College, SUNY Downstate, and Queens College continue to seek fieldwork placements in early intervention and early childhood programs. This is a great opportunity for EI agencies to mentor graduate students and to find new EI professionals to work with in the future. I say take advantage of this opportunity. Next slide, please, Annette. Thank you. So I also want to mention that we have 2 new academic partnerships with Brooklyn College and Lehman College's speech-language pathology programs. This is very exciting. They both speech programs plan to develop an EI core specialty in early intervention within both their master's programs. In upcoming LEICC meetings, we will show updates on their work. Thank you very much. Any questions?
Thanks, Jeanette. We have a guest speaker, Angela Mora Vargas, who's the Assistant Vice President of Programs at MHA New York City, and she's going to talk about Family Resource Centers of New York City and Circle of Security Parent Coaching.
Okay, here we go. Good morning, everyone. I'm here today to discuss the Family Resource Centers in New York City. I'm hoping the PowerPoint will be joining us in a little bit, so we can begin. But what's very important for everyone to note is that the work that you do every day is work that you don't need to do in silo. The Family Resource Centers in New York City provide support and advocacy to families that have children ages 0 to 24 years of age that might be experiencing emotional or behavioral or mental health challenges. The work that we do really speaks to the need for families to be connected sooner rather than later. The Family Resource Centers are across the 5 boroughs. There are currently 2 resource centers in the Bronx, 2 in Manhattan, 2 in Queens, 1 in Staten Island, and 2 in Brooklyn. So they're readily available and ready to assist you in the support that you're doing with families. Specifically, the Family Resource Centers in their advocacy and support to families work to refer and identify additional community supports that families might need to be able to move forward in better having services for their children who again might be experiencing emotional or behavioral or mental health challenges. One piece of service that we really want to highlight today is the Circle of Security parenting classes that are currently available through the Family Resource Centers. So the Circle of Security curriculum is really based on attachment theory. And these classes are really geared for parents of little ones, ages 0 to 5 years of age. And it's an 8-week session model. Each class is about an hour and a half in length. And the curriculum, again, really talks about attachment through a DVD-based session where parents are able to view interactions between parents and little ones and then be able to really process what they're looking at and really learn new techniques and the importance of that early attachment and for little ones to feel secure to really explore their world and how parents can best respond and really help a child feel secure enough to, again, explore their world and really be able to respond to their emotional needs. The Family Resource Centers provide these Circle of Security parenting classes across the city, and we are hoping that this presentation would result in possible collaborations between the Family Resource Centers and any of your sites. The Family Resource Centers are readily available to go out to any of your sites and provide these classes for free. What's important to note is that the classes provide Metro cards. At times when there's a need for childcare, we are able to provide on-site childcare. We provide healthy light refreshments, everything that families need to really be able to attend these classes and be able to be successful in completing them. The Circle of Security model in and of itself is an evidence-based model. It's been offered all across the country. Currently, there's Circle of Security facilitators in many countries across the world at this point. So it's a very recognized model. Again, it's readily available to all of you. If you'd like to connect to your local Family Resource Center, they'd be more than happy to start discussions on starting a Circle of Security at your site tomorrow. So our hope, again, is that we can really collaborate and start these classes at your sites. After this presentation, my hope is that Ms. Rochelle Macer and I can forward you over the contact information for the 9 Family Resource Centers so that, again, you can connect with them and start this collaboration. So does anyone have any questions?
I just want to apologize for the fact that your PowerPoint presentation did not find its way to the computer this morning, so apologies for that. But it will be then emailed to the LEICC members, and if you want to include other contact information beyond what's in the PowerPoint, please send that to Felicia. We will attach it and send all of the information out to the LEICC. So apologies, but thank you so much for spending the time to meet with us this morning.
Thank you. Thank you. We're going to move on to our LEICC committees. Jacqueline Shannon is going to talk about the Academic Preparation and Professional Development Committee, which is sort of a change to the previous committee, which she'll talk about.
Hi. Also, actually, regarding when Jeanette had talked about courses, one of our courses that we'll be offering in the fall, a third parenting course, is going to be really an emphasis on reflective practice, and that's one course that we thought people who are supervisors, because they had that the 3-day workshop training last fall, and there was a huge interest in it. So we will let others know about that, because that may be one course that people may want to do and not do the full advanced certificate. So the new committee that I'll be overseeing was something that Mary Bay had started, looking at the Mentor Support Education Network Committee, and we've revised it and to shape it. We were calling it the Academic Preparation and Professional Development Committee. So to pull together the various partners that Jeanette just talked about, and to help to begin to think about and address some of the issues that were brought up earlier. So our purpose is to really troubleshoot issues related to pre-service early intervention preparation, as well as postgraduate professional development and support. So both the new as well as those who have been around a while. There are 6 key areas: learning about and integrating evidence-based family-centered best practices into the evaluations in our services. The second will be focusing on acquiring and using knowledge about both typical and atypical early childhood development during assessments and designing strategies. The third would focus on understanding cultural and linguistic diversity factors, how they influence families' ideas and expectations about development, values, and lifestyles, and their impact also on evaluations and services. Knowledge about the parent-child dyad and using this information when working with families, as well as knowing and using self-reflection and reflective practice when working with parent-child dyads, and being culturally competent. As well as finally, the 6th one, facilitating and enhancing our fieldwork placements with early intervention provider agencies in the early childhood settings in both the home and the community. So this would be a partnership that would consist of faculty in the various colleges across the city, but also thinking about trying to get providers that would be members of that, so that we can work together in strengthening the workforce, both the current and new. So thank you. Any questions?
Okay, thank you. Karen Samet is the new chair of the Transition Committee.
We are going to continue work that has been started on this transition committee. I believe there were 2 committees prior to this present committee, and we're working on trying to bridge the transition from children leaving EI and then going on to preschool special education. And of course, some children are not going on to preschool special education, we would include that as well. I know that there was a lot of work done on documentations that would be available to the public and to early intervention providers on transition, and I assume that we will be continuing to work on that. There was also, at one time, there was work and discussion on possible preparation of a booklet, a pamphlet, that similar to what they have when students are transitioning from preschool to school-age services. I know there was work at one time on a document that would be a pamphlet for families and professionals on transitioning from EI into the preschool system. Obviously, it's the same education law, but there are two different systems that are bridging together as children transition. And at one time, there was a very, I believe, in my opinion, very successful meeting with EI service coordination providers and CPSE, preschool special education administrators, and there was work on working together as we help children transition from the two systems that are similar but also have a lot of differences. And I am hoping that we will be able to continue work on that. That's all I have to report.
The Policy Review Committee has not had any policies to actively review, so there is nothing to report there. So we do have one public comment, Scott Mesh from Los Niños. It's right over there.
Sure. Okay, thank you. So I just wanted to make sure that people in the EI community were aware of the new Department of Labor regulations that were presented in March, particularly because of the effect on early intervention. These are the regulations which, basically state that if someone is earning less than $46,476 per year, then by virtue of that, they're most likely going to need to be an hourly employee. And then in addition, the second basis would be the type of work. So I think this probably affects service coordination in particular in the city, and in particular fee-for-service service coordinators. So we've gone through an analysis to determine whether that would be, whether a fee-for-service service coordinator would be permissible effective December 1st when the federal regulations go into effect. In addition, there's state regulations. So that's it. Just want to make sure people are aware so that they're doing their due diligence and their analysis to determine if they're in compliance.
Thank you. Any other issues from the council?
If you're interested in the committee,
Yes. And you can copy Felicia. Anything else? So thank you, everybody. Our next meeting is scheduled for November 15th. Everybody have a good day.
Right?